Hi, in this session, we'll discuss the questions of surgery asked in this CBT. So there are two CBTs, this is the second one. So in this, let's start with the first question. What is the side effect of mefenide acetate in burn dressing? Mefenide acetate is a local antibiotic which is used in burn. The advantage, first if we talk about the mefenide acetate, is it can penetrate the eschar. It can penetrate the eschar and it can go beyond the eschar and can give its antibiotic effect. The other local antibiotics are not capable to penetrate the eschar, and also it is highly effective against Pseudomonas. But the side effect of mefenide acetate is, first of all, its application is painful, and the second thing is, in large quantity it can lead to metabolic acidosis. Neutropenia is a side effect of silver sulfadiazine. Hyponatremia is a side effect of silver nitrate, although these days silver nitrate is not used. So metabolic acidosis is the answer. All of the following are high risk lesions for the developing of oral cancer except speckled type of erythroplakia or erythroleukoplakia, it is high risk. Proliferative verrucous leukoplakia is high risk. Chronic hyperplastic candidiasis is high risk. Oral lichen planus is a low risk. Okay, maximum risk these days is seen in speckled leukoplakia. Speckled leukoplakia or erythroplakia is basically means that there is whitish as well as reddish patch there. Okay, so that is also known as erythroleukoplakia. Erythroleukoplakia, so that has the maximum risk of turning into a squamous cell cancer of oral cavity. When a post-operative bladder injury is diagnosed following laparoscopy, what is the most effective method of treatment? See, bladder injury can be intraperitoneal or extraperitoneal. Intraperitoneal is less common, but remember, in intraperitoneal treatment is always surgery. You have to do laparotomy, you have to do the peritoneal lavage, and you need to close the bladder mostly in 2 layers using the absorbable suture. In extraperitoneal injury, usually the treatment is just put a Foley's catheter, let it be there for like approximately 2 weeks, and most of the time it will heal on its own. So let's see. Foley's if it is an intraperitoneal, that is wrong. Open repair if it is extraperitoneal, that is wrong. Open repair if it is intraperitoneal, that is true. Okay. It is required, intraperitoneal needs some surgical repair. Extraperitoneal, no need of any repair, just Foley's catheter. Okay, so C is the correct answer. For the renal cyst with increased number of septa and prominent calcification in a non-enhancing cyst wall. So as per the Bosnia classification, class 1 cyst is a thin-walled cyst which does not have any septation inside. 2 is well-defined wall with well-defined wall sorry, with 1 or 2 thin non-enhancing septa. 2F is, again there is increased number of septa and you might see a solid nodule or calcification, which is again non-enhancing. 3 is multiple enhancing septa, enhancing septation, and 4th is when there is irregular wall, enhancing nodule, irregular enhancing nodule. So if we see in these 5 types, In these cases, the risk of malignancy is almost nil. Almost you can say 0 to 2%, so you don't need to do anything. In this case, risk of malignancy is around 5 to 15%. So these F means follow-up. You need to do follow-up in these cases. In 3, the risk of malignancy is almost 50%, so you need to take biopsy in these cases. And 4, the risk of malignancy is almost like 90 to 100%, so you will do a surgery. Okay, so this is 2F. As per the question, the cyst is 2F. So they need follow-up. Next question, relationship between the upper and lower pole orifice in complete ureteral duplication. See, duplication is a condition in which from a kidney, 2 ureters will arise. Okay, so one ureter comes from the lower pole, comes and opens into the bladder, and another ureter comes from the upper pole. So in complete duplication, this upper pole ureter will turn and it will open. This will open distal and medial to upper pole ureter. Distal and medial to the upper pole ureter. This is also known as Weigelt-Mayer's law. And also this distal ureter, most of the time it can become ectopic. It can become ectopic and it can open distally in the urethra also. Okay, so that's why they are asking upper pole. Is cephalad means superior, so this is wrong. It does not join the lower pole ureter, that is incomplete duplication. Caudal and medial to the lower pole orifice, this is the correct. This is the correct statement. It is caudal means lower and medial to the lower pole orifice. Which of the following devices provide the least amount of adjacent tissue damage during normal usage? So this is about the energy source during the surgery. We use many type of energy sources. Electrocautery is a diathermy. It is a diathermy. There are 2 types. One is monopolar and one is bipolar. Okay, in monopolar, the current it looks like a pencil. There are 2 buttons, yellow and blue. Yellow one is for the cutting mode, so it will cut it like a scalpel. And blue is the coagulation mode, that will cause, it will at the same time it is cutting as well as it will coagulate those small blood vessels. In both these cases, some lateral spread to the current or energy occurs and it might damage the the tissue. Bipolar, it looks like a forceps, and here the current passes from one prong to the other, so it does not pass through the body. So that's why in the bipolar cautery the lateral spread of current is less and also it will not pass through the body. Argon beam coagulation, argon plasma coagulation, usually in these cases, suppose this is the area where bleeding occurs, so in these cases you don't have to touch the tissue. Your instrument will come and it will give this argon and it will cause coagulation. Usually it will stop the bleeding by, from a distance you can, you don't have to touch that tissue. So in all these cases a lateral spread occurs, but harmonic scalpel, in these cases the lateral spread does not occur. Okay, based on the ultrasonic energy, where the blade vibrates at the frequency of 55,000 Hertz. So it will cut, at the same time it will seal the blood vessel also. Okay, it will cut and seal the blood vessel at the same time up to 5 mm. These new these new harmonic scalpel can seal up to 7 mm, but otherwise up to 5 mm blood vessel it can cut and seal. So the lateral spread is minimal in harmonic scalpel. I mean, you can be very close to an important structure and you can still use harmonic scalpel. It will not go laterally. Which of the following statement regarding penile cancer is false? Cancer may develop anywhere on the penis. That is true statement. Mostly it occurs in the glans and the coronal area, but it can occur in the shaft of the penis also. Because of the associated discomfort, patient usually present to physicians within first month of noting the lesion. This is wrong. Okay, because of the lesion on the penis, many times the patient feels embarrassed and they generally come late. Initially, they will put some ointment and they will ask from random people that what is happened, maybe from a close friend. So they generally don't present early. Usually they present later on when, despite every other possible remedy, the lesion has not subsided, it is increasing in size. Then they ultimately come to the doctor, and when you take the biopsy of that lesion, it comes out to be squamous cell cancer. Phimosis may obscure the nature of lesion. That is true. Phimosis is inability to retract the penis, and if you cannot retract the penis, you cannot see. If you cannot retract the prepuce, I mean, you cannot see what is underneath that, and that's why it can obscure the lesion. Also, phimosis is a risk of penile cancer. Because of the phimosis, the person cannot maintain the local hygiene, and due to accumulation of that smegma, it is a risk factor for penile cancer. Penetration of Buck fascia and tunica albuginea by the tumor permits invasion to the vascular corpora. So corporal invasion usually occurs late. In the initial period, this Buck fascia and the tunica albuginea give some support, give some resistance to the spread of tumor cell, but ultimately it will go into the tunica albuginea. That lesion is usually considered as T2. If it is not gone, then it will be T1. So all these following statements are true except B, the patient does not come early. 42-year-old man has a CT scan 36 hours after an accident, and the most likely diagnosis in the CT, if you can see, this is liver, gallbladder, this is the left kidney, these are the bowel loops. So left kidney, you can see it is enhancing, but on the right side you can see it is non-enhancing. The contrast is not going in this kidney. So it is because of the only possibility why the right kidney is not enhancing is the main renal artery occlusion. Okay, the main renal artery is occluded, and because of that the blood is not going into the kidney, and that is the reason you cannot see the kidney enhancing on a CT scan. Okay, long question. I'll tell you the basic thing. A female, and she had pancreatitis and she was hospitalized. Now 5 weeks after the admission, she is doing everything fine, no complaint of pain and everything. CT was performed, which shows a 9 centimeter pancreatic fluid collection suggestive of a pseudocyst. So she's having a pseudocyst post pancreatitis, but she does not have any major problem because of that. She's doing well, she's accepting only. WBCs are also fine, HF, hepatic function, liver function test is also normal, amylase, lipase, everything is normal. There is no early satiety fever. So she is just having a pseudocyst which came on the imaging. Otherwise, this is the pseudocyst. Otherwise, she is doing absolutely fine. So what is that treatment? The question is, what should you do? So if the pseudocyst is not causing any problem, you can very well wait and watch, and most of the time the pseudocyst will regress on its own. So expectant management with repeated imaging in 6 weeks. Percutaneous drainage, you will see if there is infection occurs in this. Endoscopic or surgical cystogastrostomy, if there is significant symptoms occurs because of this. If it is not subsiding, patient is having fever, or patient is having recurrent vomiting, or it is compressing some nearby neighboring structure which is causing discomfort to the patient, then in those cases you have to intervene. Otherwise, if just on an imaging it comes out to be pseudocyst, not causing any problem, you can also wait and watch, and most of the time, 75% of the time, that cyst will resolve on its own. Next question, a 54-year-old female, and nausea, vomiting, jaundice, abdomen is fine, sclera is also fine, bilirubin is borderline, alkaline phosphatase is okay, everything is okay, MRCP is shown here. So you can see MRCP image. Consider this as liver, this is the right hepatic duct, this is the left hepatic duct, common hepatic duct, and now you can see there is a huge dilatation in this CBD. So this dilatation of the CBD is choledochal cyst. So this patient is having choledochal cyst with some nausea, vomiting and mild jaundice. What will you do? Okay, so even if choledochal cyst is not causing any problem, still the recommendation is to go for surgical resection, because choledochal cyst, there is increased risk of malignancy. Increased risk of malignancy of the bile duct as well as of the gallbladder, and sometimes it can cause increased risk in duodenum also. So the choledochal cyst is most of the time resected if the diagnosis is made. Okay, the classical clinical picture you will see, there is, in these cases you will see pain, lump and jaundice, and all these symptoms are usually intermittent. MRCP is the investigation of choice, treatment is resection. Todani classification is the classification, very important for exam. Remember the Todani classification. 40-year-old depressed and schizophrenic man jumps from a building. Paramedics arrive on the scene within 5 minutes and he is rushed to the emergency, but before he reached, he was declared dead on arrival. So what is the most likely cause of death? The patient jumped from a window and fell on the ground. So this falling from a height is also a type of deceleration injury. He's falling from with the height with the speed of like gravity, and suddenly he stops. So that is a kind of deceleration injury. And in deceleration injury, one very important life-threatening injury which occurs is the thoracic aortic transection. And remember, the most common site is this. This is the area where it transects. That is also known as aortic isthmus, where it is relatively fixed, and this is the area when a transection occurs. If it is complete tear, the bleeding will be so massive that the patient will be dead before anybody can do anything. See, they reached within 5 minutes, but still the patient could not be saved. Okay, if the injury is partial in the form of a pseudoaneurysm or in the form of a intimal tear, then in those cases usually treatment is possible and patient can be saved. Tension pneumothorax can be a possibility, but see, in the question nowhere it is written that the patient is having any breathlessness or something, and otherwise this emergency team also would have put a needle if they were suspecting tension pneumothorax. Abdominal aortic transection does not occur like this. Usually it occurs because of some penetrating trauma. Ruptured spleen could be a possibility, but in ruptured spleen the patient will not die in like 5 minutes. Okay, it will cause a hematoma, it will cause hemoperitoneum, but in most of the cases you can save the patient if it is ruptured spleen or ruptured liver. Thoracic aortic transection, until unless it is partial, it is almost fatal. Next question, 42-year-old female, bulging eyes and symptoms of hyperthyroidism with palpitation, heat intolerance, anxiety. All these features are of thyrotoxicosis. What will an iodine uptake scan will show? Okay, so the patient, all these symptoms are fitting. Bulging eyes is also there. It is fitting Graves' disease. So in Graves' disease, where there is generalized, you can say the whole thyroid gland, both right lobe and left lobe, will be enlarged. And if you do a radioiodine scan or radioactive iodine uptake, you will see there is increased uptake by both lobes. Okay, no uptake is seen in thyroiditis, which is most of the time hypothyroidism. So this is wrong. High uniform uptake through both the lobes is the answer. High multifocal you will see, suppose there is a multinodular goiter, and in multinodular goiter one of the nodule is excessively secreting, so then you will see a multifocal uptake in both the lobes. Unifocal uptake you will see if there is only one of the lobe is increasing. Okay, so B is the answer. Graves' disease, a uniform uptake by both the lobes as well as isthmus. 42-year-old female underwent thyroid lobectomy for a large nodule causing compressive symptoms. FNA showed benign colloid nodule. So FNAC shows it is benign, but when you did a thyroid lobectomy, or you can say hemithyroidectomy, that is almost same thing. So after removing one of the lobe and isthmus, you noted that actually it is a papillary thyroid cancer. What is the next step? So papillary thyroid cancer is a low-grade type of thyroid malignancy, and in most of the cases, if there is no high-risk features like high-grade tumor or history of radiation, distant metastasis, lymph node metastasis, then up to 4 centimeter tumor, we can very well do a hemithyroidectomy. So this is not even a centimeter, 5 millimeter, and hemithyroidectomy you have already done. So what is required next? No further treatment. No need of completion, because that is for the high risk features or when that size is more than 4 centimeter. Next question, after cholecystectomy, the specimen shows thickened with prolapsed glands and subserosal tissue. USG shows a very classical comet tail appearance, which is seen in adenomyomatosis. Adenomyomatosis, this comet tail appearance is seen. It is not a pre-malignant condition. Okay, so you don't have to worry anything about this. This Rokitansky-Eskov sinuses is basically, suppose this is the gallbladder and this is the mucosa. At many areas, this mucosa has indentation in the wall of the gallbladder. So these mucosal indentations are Rokitansky-Eskov sinuses, which is appearing as a subserosal tissue. So that is basically the mucosal, you can say, kind of intramural diverticula in the wall of the gallbladder. 19-year-old woman presented to the emergency after ingesting car battery following an argument, whatever. Her abdomen was tender, but there was no peritonitis. If it is peritonitis after this corrosive ingestion, you have to do surgery. Okay, there is no doubt about it. But there is no peritonitis and no palpable surgical emphysema. Surgical emphysema means there is rupture of the esophagus, because if esophageal rupture occurs, the air will come into the mediastinum, which will cause subcutaneous emphysema. And there was no airway compromise also. Which of the following should form as a part of initial management? So in case of corrosive injury, suppose there is a complete tear of the esophagus, you have to operate. Peritonitis, you have to operate. But in this case, both the things are not there. So the next thing you will do is, after initial resuscitation and all, the next thing you will do is you will perform the endoscopy. Endoscopy should be done early. Early means preferably in 24 to 48 hours. And after endoscopy, you will have a grading. You will know that what is the grading of this tear, whether it is grade 1 or 2 or 3. And accordingly, you will treat grade 1, 2 or 3. In 3, most of the time you have to do surgery. When there is necrosis of the wall, gangrene, you have to do surgery. In grade 1, there is only, you can say, edema, erythema. And grade 2, there is kind of variable superficial injuries are there. So in 1, you don't have to do anything. You can allow the patient orally. In 2, most of the time, you need to do a feeding jejunostomy or the feeding gastrostomy. And ultimately, there will be esophageal stricture formation occurs. So you will wait for approximately 6 months, and after 6 months, 3 to 6 months later, you will do a esophageal resection, and you can do a gastric pull-up surgery, or you can do a colon replacement in that area. Okay, next question. 42-year-old man, emergency department with hematemesis and melena. Hematemesis and melena means there is upper GI bleeding, which is commonly due to peptic ulcer. He had past medical history of gout and increased the dose of ibuprofen. So this is also going in favor. There is chronic NSAID intake. Endoscopy shows this kind of picture. Forest classification. See, forest classification is the classification of upper GI bleed on endoscopy. So as per the forest classification, 1A is when there is active pulsatile bleed. Okay, you will see pulsatile bleed. 2 is oozing. Means there is active bleeding, but it is not pulsatile. That is, in fact, 1B, oozing. 2A is when there is a visible vessel at the base of ulcer. You will see a vessel, but it is not bleeding. Visible vessel. 2B is when there is adherent clot, which is actually this. 2C is when there is black dot, and 3 is when it is a clean base ulcer, means there is no vessel, no clot, no dot. So in 1A, 1B and 2A, these are high risk of rebleeding. In these cases, the chances of rebleeding is high. 2C and 3, low risk, and 2B is intermediate risk. So this is an adherent clot, so this is 2B. 2B. Next we'll see 21-year-old man brought to the emergency with penile pain and swelling following a fall on the crossbar of a bicycle. This is a fall astride injury. Fall astride injury, or you can also call it as straddle injury. Penis is edematous, bruised, and there is blood at the urethral meatus. All these features goes in favor of urethral injury. Urethral injury can be of two types, bulbar and membranous. Bulbar is more common. Membranous is usually associated with pelvic fracture. So these superficial perineal hematoma you will see in bulbar type. In membranous there will be deep perivesical hematoma which will not be seen in the perineum. Okay, so whether it is bulbar or membranous, the initial treatment is, remember, don't put a Foley's catheter. Go for a retrograde ureterogram or RGU. This will tell you that where is the injury and whether it is partial or complete. After that, in case of partial injury, you can take one gentle attempt of putting a Foley's catheter by experienced person, one single attempt. If it is going easily without any resistance, you can put it. Otherwise, don't put a Foley's catheter, go for a suprapubic catheterization and later on do a urethroplasty. A newborn female infant is born to 19-year-old gravida 1 para 0 who smokes. So there is history of smoking, female born. Small bowel is eviscerated through the abdominal wall, which is shown in this. So what is this condition? This is a condition known as gastroschisis. Omphalocele is a condition in which there is defect in the anterior abdominal wall, but that is covered with a thin flimsy layer, and through this thin flimsy layer you can see the underlying bowel and all. So in this case the bowel will not come out, it is covered by a membrane. Ectopia vesicae is a condition in which there is defect in the anterior abdominal wall below the level of umbilicus, and you will see the urinary bladder which is seen without without the abdominal wall covering it, and in these cases even the anterior wall of the bladder is also absent. What you will see is the posterior wall of bladder with the ureteric opening and the urine is coming from it. Necrotizing enterocolitis is a infected condition of the small intestine mostly, which is seen in the preterm babies and the low birth weight babies, and in these cases in the intestine there is dilatation, and inside the wall of the intestine there is presence of air that can be seen nicely on the X-ray. So in most of these cases you have to keep the child nil per oral for few days and then you treat these conditions. Usually carries high mortality. Next question, 45-year-old female screening mammography demonstrates ductal carcinoma in situ. Which of the following is true about this condition? Ductal carcinoma in situ needs to be excised. It is a cancer and we should do a wide local excision taking at least 1 centimeter margin. So it should be excised to a negative margin. It is considered as a malignancy in either breast. This statement is good for lobular carcinoma in situ. Lobular carcinoma in situ is considered as a marker for malignancy in either breast. The cribriform type has a worse prognosis. See, ductal carcinoma in situ has different types: comido, solid, cribriform, papillary and micropapillary. Out of these, comido is a high grade type and it has worst prognosis. These are low grade, solid is usually intermediate grade. Okay, so Comido has worst prognosis. Cribriform is usually low grade. Radiation therapy is an acceptable alternative. It is not an alternative to ductal carcinoma in situ. It can be used as an adjuvant in few cases, but it is not an alternative. You have to do surgery. It is not an alternative to surgery. Next question, 45-year-old female, dyspepsia, and there is no major problem, no weight loss. H. pylori antigen is found to be positive. Patient was treated with quadruple therapy. Right upper quadrant ultrasound was performed which revealed a 12 mm fixed hyperechoic shadowing in the gallbladder. Okay, so suppose this is gallbladder. So this is that hyperechoic shadow which you can see. Now this hyperechoic shadow could be a gallstone or could be a polyp. But the important feature why it is not gallstone, because in the gallstone you will see the posterior acoustic shadow, which is not seen in this case. There is no shadow. So that's why it is not a gallstone. So if it is not a gallstone, then it is a polyp, gallbladder polyp. So in the gallbladder polyp, the management depends on the size. If it is less than 10 mm, then you will do follow-up. If it is more than 10 mm, then in these cases you have to do a cholecystectomy, because a gallbladder polyp more than 10 mm increases the risk of gallbladder cancer. So in our question it is 12 mm, so you will do a cholecystectomy. Genitourinary tuberculosis in a male patient is suggested by which of the following finding? Pneumaturia is a condition where you will see air coming or the bubbles coming in the urine. Usually it is seen in like when there is colovesical fistula. When there is a fistula formation between colon and the urinary bladder, many times in case of diverticulosis you can see this condition. Painful swelling of the epididymis is not a feature of TB. In TB you will see painless swelling. Epididymis swelling can be seen, but usually it is painless. Bacteriuria without pyuria is not correct. It is rather reverse. That is, you can say the patient will complain that the pus is coming in the urine, but when you send the pus urine for the culture, you will not see any gram-negative or positive organism, because when we send it for culture, usually they check for the bacteria. They don't check for the mycobacteria. So you have to specifically send the sample for urine for AFB, that is acid fast bacilli. So usually the report comes out as sterile pyuria. In TB you will see sterile pyuria. Hematuria, microscopic or macroscopic, is very frequently seen in tuberculosis. Next question, 36-year-old man, emergency renal colic, 1.5 centimeter stone. Which of the following regarding this disorder is correct? 1.5 centimeter. Up to 6 centimeter, there are chances that the stone will pass spontaneously. Up to 6 millimeter. 6 millimeter to 1 centimeter, there is still like 20% chance that it will pass. But after 1 centimeter, the chances of spontaneous passage is almost negligible. This is 1.5 centimeter. So conservative treatment will not result in a satisfactory outcome. Okay, it will not result in satisfactory outcome. Serial kidney, ureter and bladder radiograph should be used to follow. You should not follow these patients. 1.5 centimeter stone, you should try to get rid of this stone by doing ESWL can be a good option in these cases. Otherwise, if ESWL is not possible or contraindicated, PCNL can also be done. Okay, these days people are doing RIRS, which is in fact in this size, this is in fact these days the treatment of choice. Open or laparoscopic surgeries are rarely done for the stone. So if you do follow up, there are high chances that it will ultimately causes some obstructive uropathy and the renal damage can occur. The urine analysis will nearly always reveal microhematuria. In case of stone, microscopic hematuria is very frequently seen. When acute event is correctly treated, the disease seldom recurs. Acute event is that renal colic or the ureteric colic. So when acute event is usually lasts for like 30 minutes to 2 hours and the patient is having severe pain. But for that pain, you will usually give diclofenac. Diclofenac is the drug of choice, and NSAIDs. But that is just for the pain relief. Again, it will happen. Again, it can cause problems. So that's why the disease seldom occurs. That is absolutely wrong. After acute event, you manage it with the analgesic, and later on you will do some kind of definitive treatment to get rid of the stone. So C is the only correct answer. Unrestrained means the seat belt was not used, head-on collision, damage to the vehicle, and he was removed from the vehicle after some time. Unstable patient, transported to trauma center. During transport, severely hypotensive, unresponsive with respiratory distress. Which of the following is considered as a life-threatening injury to this patient? This is very easy question. Among all these, the most dangerous is tension pneumothorax. Okay. Why we are saying tension? Because see, hypotensive. Only in these cases, tension pneumothorax patient will be hypotensive. And severe respiratory distress. So that's why tension pneumothorax. We all know tension pneumothorax. First you put the needle in the fifth intercostal space to immediately decompress, and later on you will put a ICD. 20% burn on referral criteria. What is the referral criteria? Partial thickness burn more than 20%. All full thickness burn. If there is a burn on face, neck, hand, feet, genitals, major joints, any chemical burn, electric burn, or any inhalational injury, you should refer. Burn with trauma, you should refer. And burn in a patient with coexisting medical disorder. Suppose patient is having history of coronary artery disease or history of stroke. So in these cases, it is better you send the patient to a specialist burn center. So burn of 20% or more should be referred to a specialist burn center. Partial thickness burn, not 20%, these days it is said 10%. More than 10% burn you should refer. 10% is good enough to refer the patient. Newlywed man presents the emergency intense pain in the penis. Newlywed. He reports having accident, falling in the bathroom. Temperature is okay, BP is okay, pulse is slightly high. Physical examination, blue discoloration at the base, deviated penis. He has no ulcers or discharge. Retrograde ureterogram did not identify any urethral injury. What is the best next step in this patient? Okay, so this is very classical history depicting fracture of penis. Fracture of penis, usually it happened in the erect penis at the time of sexual intercourse. At the time of sexual intercourse, there is some, is a click type of sound is heard, and the tunica albuginea layer of the corpora cavernosa gets damaged, and suddenly the erect penis becomes flaccid. There will be hematoma around the penis. The penis looks deviated, kind of broken. It is also known as eggplant deformity. Okay, so in these cases, you cannot do any of these things. You have to do surgical repair. There is nothing apart from surgical repair. Okay, in surgical repair, all you have to do is expose that tunica corpora cavernosa and tunica albuginea and just put 2-3 sutures and repair the defect. Most of the time, because it occurs at the time of sexual intercourse, so people, they try to hide the history and they give these irrelevant thing, accident, falling in the bathroom and all these. This does not occur by falling in the bathroom. Okay, so surgical repair is the answer. Next question, emergency department, trauma to the head and neck. Systolic pressure is low, heart rate is low, GCS is low. CT reveals epidural hematoma. Cervical spine demonstrate vertebral dislocation at C4. What is the likely cause of his hypotension? See, if it is head injury, in case of head injury, patient develops hypertension, bradycardia, and irregular breathing. That is known as Cushing's reflex. So this patient's problem is not because of head injury, because there should be hypertension. What else the patient has got? Spine injury. So spine injury can lead to neurogenic shock. In neurogenic shock, there is vasodilatation. Peripheral vasodilatation occurs. That will lead to hypotension, bradycardia, and warm periphery. So that is fitting our patient. This thing is fitting our patient. So our patient is in neurogenic shock. And why neurogenic shock occurs? Vasodilatation. Vasodilatation. Which intraoperative technique during parotidectomy is used to locate the main trunk? Identification of posterior aspect of sternocleidomastoid will not be helpful. It is the posterior belly of digastric is useful. The cartilaginous part of the external auditory meatus, that is Conley's pointer, that is useful. Tympanomastoid suture line, stylomastoid foramen, or you can trace from a peripheral nerve to the main trunk. Okay, so instead of anterior there is posterior. Sternocleidomastoid is not used. Greater auricular is not a part of the, not a branch of the facial nerve. So option number C is the correct. True regarding phyllodes tumor present in older female when compared to fibroid tumors. Yes, usually phyllodes tumor is seen in the age group of, like, you can say 30 to 45. Fibroadenoma 15 to 25. So this is true. Are rarely malignant, less than 10% are malignant, mostly benign. True. Require wide local excision taking 1 to 2 centimeter margin. That is also true. So all of the above statements are true. Young female, history of fever and pain in the submandibular region, and she's having trouble speaking also. And the floor of mouth is indurated, swollen, and very tender. Poor dentition. So all these features are going in favor of Ludwig's angina. So Ludwig's angina is a type of cellulitis of the submandibular area, usually caused by streptococcal and anaerobic infection. The origin starts from a dental problem, caries of the tooth or dental abscess that will spread to this submandibular space. In untreated spaces, it can spread to the parapharyngeal or retropharyngeal spaces also. But the main problem is this much swelling in this area can lead to serious airway obstruction. And that demands some kind of surgical intervention, because when this whole swelling is there, you will not be able to do either fiber optic or proper endotracheal intubation. So that's why in these cases you need to do a surgical airway in the form of tracheostomy, and later on you can treat this condition. Last question, history of medullary thyroid cancer. He underwent total thyroidectomy. Now there is poorly controlled hypertension, severe headache, and palpitation. Catecholamines are elevated. MRI is performed. So see, medullary thyroid cancer, this is very typical of pheochromocytoma. So basically we are dealing with a patient having MEN2 syndrome. Which of the following medication should be initiated? If it is pheochromocytoma, before treatment you have to give preoperatively phenoxybenzamine, which is an alpha blocker, and later on you will give a beta blocker after the alpha blockade is complete, and then you will do the surgery. That is adrenalectomy. Okay, so thank you very much. The questions were a bit on the tougher side, but if you can correlate these clinical based questions and image based questions are very frequently asked these days. Okay, so when we practice the tougher questions, we remain prepared for the easier questions which are going to come in your exam. Okay, so all the very best for your exam. The questions will be very easy. There will be lots of questions from surgery, and I hope that all of you will do most of these, in fact all of those questions correct. Thank you very much and best of luck.